Okay, so my learning objectives, you can see here, I only have 20 minutes and I could probably talk for an hour, but I think the really important key discussions are trying to understand why we as healthcare professionals need to talk to children and their parents about receiving the COVID vaccine, and then how we can do that, how we can establish ways to approach that. And so when I was thinking about this opportunity and speaking to other healthcare professionals, I just kind of wanted to let you know the thoughts that really encompass my mind. You know, sometimes I do get frustrated. I do have minimal time sometimes to have those difficult conversations, but then I like to bring it back into, you know, why I'm doing this and what do I believe and how I can explain it. So I think that those are key features. And so sometimes I think about history and really the history of vaccines and, you know, what the impact has been. And so early 1700s, when we didn't have vaccines, not until the smallpox vaccine came by in the early 1800s, you know, there was obviously significant diseases that were causing mortality and morbidity. But then even our infant mortality rates were at 20% in the 1900s, and a lot of that related to infections that were vaccine preventable but didn't know at the time. But you can see that in 1918 to 1919, during the influenza pandemic, it really hit children less than 5, and that mortality rate was at 20% during that time. I wish the Salk and Sabin polio vaccine was created prior to 1954, because my mom was affected by polio in 1954, and the vaccine didn't come about until 1955. And so she was hospitalized in San Antonio and had obviously side effects from that. But you can see how things developed over time. 1960s, now we had the advisory committee, and they're still going strong on immunization practices. We eradicated polio in the 1970s. There's obviously over time been some distrust, not only in the US, but in other countries. And so you saw rising cases. Looking at pertussis, we as hospitalists still see a significant number of cases of pertussis. Even in 2013, we had close to 4,000 cases in Texas, and I was seeing quite a few at that time. And then as we have hesitancy and then immunity waning, such as in measles, we have that outbreaks of those that you know, are unvaccinated or their vaccine status has waned. And then now we're into another pandemic, and then where that approach should be. And so where I always often try to start is where our seek to understand is, okay? So why there's vaccine protest, hesitancy. Obviously, you can look at those causes. The side effects are really, you know, understandable. People get worried. They don't want to have any sort of side effects. But then there's plenty of misinformation, disinformation that we'll talk about. That disinformation, that intentional individual putting out information that is incorrect on the internet, social media, or those organizations can really be extremely harmful. And we've seen that with the MMR vaccine and autism. We've seen discussions about HPV and affecting, you know, that disinformation and saying that it can cause people to be infertile. But then we also have to think about the simple things about getting the concern about vaccine overload when your child receives, even my children receive a few vaccines in a row on those visits, and really, you know, concerns about what are in the vaccines, especially now since there's disinformation, misinformation on the internet. And then understanding that people have their personal right, and they have their children, that they want to be the decision makers, and sometimes that often gets changed or shifted to mandates. And you can see that in the 1830s, you know, intrusion of privacy and bodily integrity, you know, even talking about the smallpox vaccine really took off. And then you had individuals performing quackery that really weren't healthcare individuals, and then that proving distrust in the 50s. And then even in the early 1900s, you had Supreme Court rulings because they had vaccine mandates for smallpox, and individuals fighting and not wanting that, and then an anti-vaccine League of America forming. And so it wasn't actually until the 1980s we have this National Childhood Vaccine Injury Act to really help for, when we do have side effects and associated problems associated with the vaccines, and how we can help those individuals and resolve at least some of those issues and look at those issues a little bit more in depth. But I think, and then obviously the ongoing mandates and individuals striking, which you can see here. But then we get to COVID, and I'm not going to belabor this slide, but the CDC puts out weekly reports so that you can have access to this, but still knowing that children are affected and that they're 19% of all the cases. And then the weekly report, we're at about 27,000 children being positive for COVID, 16% of the weekly reported cases. Fortunately, childhood hospitalizations are less than 1%. And fortunately, mortality is less than 1%, but we have to understand it. We still see those children in the hospital. Children can still die from COVID, and we don't have that crystal ball to know who's affected. But we can see the COVID vaccine varies across states, and the CDC put out this data, and we don't really they commented they don't have that robust Texas data, but you can see the COVID vaccine was offered for 12 to 17, and we're looking at that first dose and second dose being received is obviously much higher than the COVID vaccine offered in October 21. We're still trying to get those children 5 to 11 vaccinated. So we still have some room to grow. The Metropolitan Health District, if we look at new cases over time, starting in June of 2020, going to January of 22, the dotted lines are really the childhood number of cases. And you can see that has increased. When we had Omicron come along, you can see by January 2022 that we had a shift upward. And then the Texas DSHS has pulled in the school-reported COVID cases in Texas public schools. The blue is the student cases. The yellow is the staff cases. So you can see over time, before we could really encourage and get those vaccines out to children, the case rates were higher. And then we had a downslope as the overall case rates decreased, but then we had Omicron come in, and we had a lot of unvaccinated children, and so that shifted up. But you can see the staff cases, those number of cases hasn't been as high, and alluding to the fact of those that have been vaccinated. And then from what I could get from Bexar County data from Texas DSHS, you can look at this. To the left is the vaccinated with at least one dose. To the right is fully vaccinated. You can look at the age groups. We have 5 to 11, 12 to 15, and you can see that is significantly different than the 16 to 49 and 50 to 64. The green is male, the purple is female, but you can see that we still have a lot to accomplish to get children to be vaccinated. And so how do you start? And so that's where we get into that preparation phase and thinking about, if you are a clinic health provider, sending out those letters to really tell your own stories. There's templated letters you can get from the AAP, and you can insert your own stories. Obviously, you want to talk about the safety and effectiveness, but you do want to talk about the side effects. And then you want to, offer that invitation in your office to have those posters to talk about the effectiveness, but also some of the side effects, and having those perhaps in your clinic room, so that while the patient and family are waiting, they can shift through that. And then, you as a clinic provider, if you have those social media websites, you can, reference pertinent sites to get to help with that misinformation, disinformation. And then if you don't offer the vaccine at your clinic sites, you have resources to look at those zip coded regions with that website to find many of the vaccine sites in your area. The other thing is development of key talking points. That's a whole nother lecture in itself, but these are the questions that you want to ask, and you want to start to answer them. either in your head or writing them down on paper, and trying to get to that point of talking about some of those problems or those questions that those parents might ask. The other thing is, yes, understanding when you do get somebody that completely rejects you. This is put out by the AAP, and understanding in the past, where people are, you can see the rejectors are actually at less than 1%. And that might have shifted. They don't have that new data just yet, but understanding that is the lesser of the population. And the majority are acceptors, but then you have that hesitant area, and that's where we can really try to redirect and try to talk to them and get to a point of what our approach should be. So me as a pediatric hospitalist, talking about the flu vaccine and understanding that, I know it's safe and effective, and I know it decreases hospitalizations. I've really, most pediatricians, if you talk to them, take that presumptive approach. And you can see the study put out in Pediatrics in 2013 that most physicians take a presumptive approach, saying, we're going to go ahead and vaccinate your child today, especially if I have somebody that has a respiratory illness that they've been in the hospital for, and I don't want them to return with the flu. It's really easy for me to say, I need to go ahead and give that flu vaccine today. But and you can see that population resists much less than if you actually invite them, what do you think about us giving the flu vaccine today? And having that participatory approach. Not too many pediatricians take that approach, but you can see the resistance is much higher at 83%. But what and Ruth, you have a question here?
Yes, I do. I think these are really, really important data. It's very important that everybody be aware that this information about the presumptive approach is in our published peer-reviewed literature and endorsed by the American Academy of Pediatrics. And my question that I have about this study, which has an N of 93, is: was this actually randomized? Was it a randomized study?
Yeah, it was not randomized. And you're actually limited on that data to find studies that do that. But if you really look at some of the presentations from the American Academy of Pediatrics and their relation, they have teaching courses from PediaLink. They're limited in what they can pull, and this is actually the one that's pulled in that is limited. But if you talk to, I think, most individuals that you practice with in your surrounding practices, you'll see a lot of times that pediatricians do take that presumptive approach. But here's the but, right? So we have a new vaccine, the COVID vaccine, and it's important to understand with a new vaccine or any sort of new treatment, taking that presumptive approach may not be the best approach at this time and moment. And so what the American Academy of Pediatrics is actually encouraging right now is to actually stray away from the presumptive approach, but still use some key features of that, and looking at making a personal recommendation is still appropriate, but we're going to talk about where that approach should now be. And so I think that's important and key, is to understand what's going on in the past, but then understanding what we have now. And this is something new and different, and that we need new tools. And so that's where we get to this new mantra of where that should be, what you can develop from what I'm presenting to you, and where we can go from here. And so I think, one, understanding how you can approach this in a weighed format is important, talking about risk versus benefit. And obviously you can see all the risks here, and we know a lot of the risks here. Even with receiving the vaccine, you have to schedule that day, and you might have to miss school or work, and then some of the side effects can lead to additional missed days. And then the concern is, as we develop for future variants, how effective that vaccine would be. But then, thinking about will there be future mandates, and the worry that that parent is going to lose their personal choice to make those decisions. But we can see the benefits weigh really high, right? It's definitely proven to be safe and effective. It limits the disease in an individual, because I can't sit there and say you're going to be hospitalized versus you are not, unless they have significant comorbidities. But we've seen missed C cases in normal individuals, and lead to long-term side effects and outcomes. But we know we want to limit transmission. We know if that child doesn't get sick from COVID, they don't have to stay at home, if they're vaccinated and they're covered. And we don't want emerging variants to occur. This is a lot of data-driven, but Dr. Berggren had discussed, it's always nice to see, because this is one of the hotter topics, COVID vaccine and myocarditis, and understanding that here's the risk benefit, right? If you have the vaccine and myocarditis, what happens? We had about 1,600 confirmed cases, usually self-limited, but they had 2 deaths still under investigation, but 98% of the cases are out of the hospital, and 87% of the cases that did occur that were hospitalized were resolved upon discharge as well. You can see the median age 16 to 31. Males were commonly affected, and that risk stratification 1 in 15,000. It's hard because you can't compare apples and apples when you're trying to look at the data. But what you have to understand is that when they looked at myocarditis cases in 2020, there was about a 45% increase in the total number of cases of myocarditis. And of those number of cases, 40% had a confirmed COVID diagnosis. So they had to retrospectively look back at this. And they found that children and older adults are most affected. That risk is approximately 1 in 700. The missed C cases, those are the cases we as hospitalists see. We've had, in the US, close to 8,000 cases with 66 deaths, and those are primarily due to cardiac illnesses. The median age is 9. That risk is 1 in 4,000 of those that are less than 21 that are COVID positive. So where do we go from here, right? And that's where this motivational interviewing takes place. You can see a little acronym expansion. Dr. Berggren, as we have the case discussions, we'll talk about her acronym expansion. I'm one that tries to kind of get in the mode and just teach myself kind of where I want to be and what I want to do. But when you do motivational interviewing, this is not to be belabored. You're trying to really hone on 5 to 10 minutes. So have an approach of one, you want to be comfortable, you want to be relaxed, you want to set up that comfortable environment, and then you want to understand your population. They come from different backgrounds, whether that be cultural or socioeconomic, and really kind of set up that approach wisely to understand that individual and that parent that's walking in the room. And then this is, again, a new vaccine, and so having that next step about asking permission to discuss the COVID vaccine. But, as I've learned, it's really wise to be specific about your actual question. So may I ask you what your concerns might be specifically about the COVID vaccine? And then may I ask what you've heard or read that is concerning specifically to you before, we make that decision to give your child the vaccine? And then understanding if they are the resistant, respecting that answer, and then, having that invite to perhaps rediscuss it in the future and maybe trying to give some tips and tricks for them. And then you can ask a scale question. Where are you at on a scale to 1 to 10? How do you feel about this, giving this vaccine to your child? And then there's the ready phase, right? The facts and tips. Be ready to respond to the questions they ask about the vaccines, and understanding, expressing that understanding. I understand you might be worried about the safety, so let's talk about that. And you don't have to bring in other controversial information. Sometimes I get into, they might be thinking this, they might be thinking that, but identify what they're bringing and specifically talk about that. And if you're not, up to date on that, it's okay to say, hey, I'm going to take a step back. I'm going to learn about this. I'm going to talk about it later. But the most, important step is to regroup, repeat, summarize, and empower that parent. Give them autonomy. Ask them where are they currently at now that you've provided these facts, and where do they feel their next steps are? Or are they going to have that willingness to vaccinate? And then the debunking, that's the biggest thing, right, that we're facing right now. This handbook, it can be accessed online in PDF format. It's really, you can go through it probably within an hour or less, just depending upon where you need to be at. But here's some key steps from this handbook. And importantly, you want to ask that parent about the resource they got and what to consider. So if they find a resource on social media, ask them, what is that individual's track record, what their motives might be. Go back and look at other resources to verify those claims with other valid resources that you can provide them. And then if you hear that myth, try not to kind of belabor it and repeat it. Just warn and then explain how the myth misleads one time. And we'll talk about an example, but explain why, it was thought to be correct. So I can see why, that you read this and why you might think that it's correct, but let me tell you why it might be wrong. So that's where you want to lead with a fact, and then you want to restate that fact. And so the Debunking Handbook has looked at some studies and found that if you're kind of repeating things or giving more facts, you're actually okay. You're not going to backfire. And the more facts that you give, you usually are not going to backfire. It's going to be okay to provide those facts. And then you're going to, talk about why that alternative, that resource you found is correct. And it's important to see that inconsistency with that myth to get to the alternative, to resolve that issue, and then putting the complicated facts into your own words. And so we're going to warm up with a quick case example before we get to our panel. But here you are with that 13-year-old female comes in with mom, and they're concerned about the ingredients in the COVID vaccine that may be toxic to my child's body. And so you want to, be specific. May I ask what you are concerned about in the ingredients, and really try to seek to understand what specifically they are concerned about. And then once you get that concern, you can say, I can see you are concerned about the safety of the products in the vaccine. So you want them to understand that you can understand that. I can understand that you care very much about your daughter and what she receives from an injection. And then get to that point of, I've put that thought in, and I've done some reading, and I'm understanding the safety of the ingredients in the vaccine. And then, in inviting them, may I share this information about what I found out? And, hopefully they're willing to listen, and then you can discuss. I've looked into my resources that I use as a pediatrician. The COVID vaccine is set at the same standards as all other vaccines for approval. Over 10 years of research had happened. So you can kind of give your mantra there. We've given over hundreds of millions of vaccines, and they've been shown to be safe and effective. The ingredients that we're using actually have sought to make the vaccine as safe to administer as possible. I feel better about giving the vaccine to my patients, even to my own children, so as to protect them from getting COVID and to protect those individuals around them. But, this is your decision that, stray away from the buts, right? But this is your decision that you can only make with your child. Where are you at? What do you think? And then, get to where they're at, understanding, and then, give them those resources. Please, as you go out, if they're not ready at that time, this is where we can debunk and where we can use those resources. So each visit is an opportunity to discuss vaccine hesitancy. We've oftentimes heard about dismissing a patient from a practice. You've got to understand this is a new vaccine, and there is some anxiety, going on, and you want to earn that trust. So, try not to dismiss. and try to seek to understand, and then explain your meanings. So try not to data drive, but if they're asking further, you can be ready for that, but you can use terms like common, rare, extremely rare, to really promote. And then use that 99% is safe instead of using that 1% experience side effects. Start with kind of the positives, right? And then you often hear about herd immunity. Kids just need to get it, and then other kids need to get it. But we have to talk about the other people that it's affecting, and the immunocompromised, the children with chronic medical conditions, the young infants that I do see with bronchiolitis in the hospital, even from COVID. And then use those open-ended questions. Stray away from that but in your responses. And then importantly, tell your stories about what you've taken care of, what you've seen. Those are important. And then if you feel that next step, talk to your local schools or your local organization. So that'll leave you with questions, but you can see my youngest two, you can see the difference in responses from receiving the COVID vaccine. And then my Jordan, she is a teenager that's been on the Moderna vaccine, and she's in the booster study now. So she is still one of the few that's received in her age group the Moderna vaccine. So excited to talk about any questions and then move on to the panel.